Hello, everybody. Good afternoon. My name is Jean Fajadet, and I have the pleasure to chair this session. And the title will be How to Decrease Operator Dependence on Vessel Opacification During PCI, a crash course on ultra-low contrast coronary intervention. So it should be certainly one of the most important sessions for me in the meeting. The concept of ultra-low contrast coronary intervention. So I have the pleasure to chair this session with my co-moderator Nieves Gonzalo and our discussant Billal Patel, Jeff Moses, Dariusz Dudek, and Javier Escaned. The program was prepared by Javier and Nieves, and in fact we have three major objectives. The first one is, if we can have the objective, to become aware of the importance of relying on less contrast injection to guide PCI in complex patients. The second is to learn, and we are here to learn, what are the skills required and the tools available to perform ultra-low contrast coronary intervention. And finally, to share together and discuss via a recorded ultra-low contrast coronary intervention from a daily life. So it is very important, personally, when we prepare this session, thanks to Javier and Nieves, I learned a lot. Because to be honest, this was not my way of working since 40 years in Toulouse. And so it's really a fascinating concept, and you will see, could discuss this at the end of the session. So, Nieves.
Yeah, so a very important part of this session, of course, is your participation. So we are looking forward to your questions. I will be checking continuously the chat so we can make sure that all your questions can be addressed during the session.
Okay, I think we can give now the microphone to Javier for this case presentation.
Thank you, Jen. And the case, I'm sure that many of you will recognize this profile of patient. Let me first share my disclosures with you. The patient is a 77-year-old gentleman who has multiple cardiovascular risk factors. You can see hypertension, diabetes mellitus type 2, dyslipidemia, former smoker. 6 months before, he had exertional angina, and it was disclosed that he had coronary artery disease. So he had a PCI to proximal RCA with a regulated stent. At that time, he had preserved left ventricular ejection fraction. It's of note, the patient has chronic kidney disease, stage 3-4. The GFR is 30 milliliters per minute, as you can see. And also, of note, he had a prior stroke, and he has documented a 60% stenosis in the common right carotid artery. Now, the current presentation is that on top of exertional angina, he has heart failure. He has now a moderate left ventricular systolic dysfunction with regional wall motion abnormalities. Now, the EKG shows sinus rhythm, narrow QRS. There is some ST depression in precordial leads, as you can see. The echocardiogram, left ventricular ejection fraction of about 40%, no valve disease. And here you have some data of the laboratory. The most relevant one, of course, refers to the presence of chronic kidney disease. Now, the coronary angiogram that was performed revealed that he had this ambiguous stenosis in the left main coronary artery, diffuse disease with all the coronary tree. You can see lots of calcium over there, like typically happens in patients who have chronic kidney disease. Have a look to this and try to think if you believe that this stenosis in the left main is significant or not. And the right coronary artery demonstrated first that the stent that was implanted in the proximal part was in a shepherd's crook right coronary artery, as you can see there. Lots of calcium as well, and you can see now a critical stenosis in the distal RCA. With this in mind, we calculated the scores, and you can see that the syntax score for PCI and CABG had an equipoise in mortality, according to the calculator. As the patient has a high bleeding risk, both from the DAPT score, but also from the ARC HBR criteria. And we set ourselves that the patient obviously was not a candidate for a CABG. Instead, the idea we had was to perform PCI, but that should be performed first with hydration and then setting an amount of contrast that will not be superior, numerically speaking, to the GFR. So that if the GFR was 30, we could only use to try to treat this right coronary artery and eventually the left main coronary artery with 30 millimeters of contrast. So this is the summary of the case. And now probably, Jean, what we could do is, with this slide as a sort of reference, go and discuss something about how to proceed with this patient and how to treat.
Any comment before moving to the lecture of Dariusz? Jeffrey.
Well, I think, first of all, there are many centers that won't even tackle this for PCI off the top, and I can testify some major centers in the U.S. won't do anyone with a creatinine over 2. Second of all, when we're evaluating the syntax score and the like, when you're thinking about the likelihood of dialysis, actually the risk obviously from CABG is higher, and that is without the conservative strategies that we're doing now to lower the risk even further. So I think the equation tilts more heavily in favor, certainly for the short term, for PCI in these type of patients.
Billal?
So, I mean, the only question I'd ask the audience is, if you were to do this case, how much contrast would you be using?
Okay, that's really a major point. So what we could do, Dariusz, we could explain us why to perform trial contrast, the PCI, and how to do it.
So my lecture will be stimulating for discussion. As Jean said, that in near past we are using a lot of contrast, and to go to ultra low contrast PCI in specific situation, but also to think about the general concept of low contrast PCI. So we are connected here very much, chronic kidney disease and coronary artery disease in that patient, so complex PCI, renal insufficiency. So first, the question is if we should do or not revascularization. Yes, we should do, because it could be beneficial for patients, and many patients with chronic kidney disease, they don't have the revascularization because operators are afraid of doing that. Second, when we go with the regular angiography and we have a patient with chronic kidney disease, so you need to use additional tools. You can convert your PCI with the imaging or other tools from the high risk to, let's say, better outcome of the patients, which will be more towards the non-CKD patients. So you need to use the additional devices. In everyday practice, we should think about the reduction of the contrast with the different approaches, with hydration, with the device, with the strategy during the procedure, and additional imaging. So first of all, we should remember that this patient is elderly patient, and we see more and more patients which are with frailty, and we need to be very careful, because if you have more patients with frailty, higher score, you have more complications. And many of them, like that patient, is with the heart failure, lower ejection fraction, multivessel disease, and chronic kidney disease. Moreover, you have the 4 times higher risk of acute kidney injury among elderly patients which are frail, so we should be very careful with doing such procedure. So be fragile with such patient. The second, when we have the second problem with that patient, is a complex coronary artery disease and you need the complex PCI. One would think to do just the right coronary artery, or maybe we should do the complete revascularization for this patient. But we should be careful because if we go for complex, if you use a lot of contrast, you can have more frequently coronary, the contrast-induced nephropathy. When you go for very complex cases like CTO, this I check with the European registry, and you can see what Jean probably said, that sometimes operators, they don't care for contrast, and we see the volumes not 30, but rather 300 milliliters. So when this is converted into the contrast nephropathy, it could be the serious problem for many patients with multivessel disease, CTO, like this slide, and or for our patients. So that's why we have some techniques which will be discussed for contrast sparing strategies. You can use easy of them with the everyday practice. We'll discuss in more details during the course. Certainly, you should also focus on the additional imaging, additional functional assessment, and preparation for this procedure to be well prepared to use as low as possible, and maybe only 30 milliliters of the contrast or even less. So that's why the imaging and physiology is important. Coming back to CTO for a while, we know that the experienced operator, they can use the ultrasound even for retrograde cases to really spare the amount of contrast used for the cases. When you have the another opportunities like the co-registration, the IFR Scout and Angio, it will facilitate your procedure. When you have the triple co-registration, it's easier to do many procedures without using contrast, and a lot of steps could be done with using those tools without the injection and pumping the contrast. So that's why we think that this new techniques and co-registration giving the more opportunity. Even when you have the patient with the chronic kidney disease and you need to do left main, you can use with ultrasound, and you don't necessarily need almost contrast, because with the good techniques, with the imaging, you can really do your procedure. So in summary, I would say that the increasing proportion of our patients are frail and elderly. The complex PCI cases, multivessel disease, CTO, done in a standard way, often requires high volume contrast in standard procedures. So sometimes for specific patients, we need this concept of ultra-loud contrast PCI, especially for those patients. However, it should be supported with the good tools to make it, which will be discussed during the session. And also, I would say that it is this technique of ultra-loud PCI contrast is opportunity for interventional cardiology to upgrade our practice to the need of 21st century, and maybe change the concept, as Jean said, from the old PCI to new PCI with low contrast as possible, and use more imaging and physiology techniques.
Thank you, Dariusz. Thank you. And I think before moving to the video case, we have a few minutes of discussion. First, in the room, have you any question to Dariusz on the lecture and on the presentation, the case presentation? Do not hesitate. There's a small room. It's behind. Nobody listen to you outside of the room. So we are together. Do not hesitate. Come on.
There are microphones there.
Microphone.
Thank you so much. I think for such case, we can go for stage PCI and physiological assessment of the left main. So every stage PCI or intervention could help in such cases.
Yeah.
Assessment with physiology, you mentioned, or?
Yeah, so you understand the assessment of physiology and to the stage procedures, yes, the right and left.
Absolutely. I think that's obviously quite an important remark. And the point is whether you want to do it at the time of the diagnostic angiogram or not. In patients like this, where our policy now, when you have someone who has impaired kidney function, is to start with a very good angiogram, just 2 angulations for the left coronary artery, typically an AP caudal and AP cranial. If you check this, you will have most of the cases all the information you need, and probably an LAO cranial for the right coronary artery. So in total, you can perform a good angiogram, and I'm sure that Jeff will elaborate on this with less than 12 cc's of contrast. And then if you wish to perform then physiology, well, I guess that with that information, you will be able to negotiate a wire and to make some measurements without additional contrast. You're completely right.
I think, Javier, the question was, if you consider to do the PCI, let's say, that is important, the SLAD and the RCA, as a one session complete, or rather you want to stage? Because with these new techniques, with the low contrast, if we use the sufficient tools, maybe we can do one session.
Exactly. I mean, that is very much aligned to what happens with complex PCI patients nowadays. For example, just to give another example, patients who have depressed left ventricular function and you're using mechanical circulatory support, is that then you gain time to perform in one setting everything. But of course, I mean, that's is not mandatory. It's something that you have to play with common sense, but you may decide.
Yeah, I mean, I think there's a question of the clinical urgency, number one. And number two, a lot of these are game time decisions. In other words, you do that severe right, if it's done parsimoniously, you could do that with virtually no extra contrast at 2 cc's. If you have headroom to tackle the left main, then the next step would be, for instance, IVUS or FFR the left main and see how complex it is, and you may defer that. I mean, these are decisions you have to make online every day. There's no specific single way to do this.
I think, using ultra-low contrast technique, it gives you that time and gives you the space in terms of contrast volume. Often with complex cases, contrast volume will be one of the major reasons why you will stop the case and not go for complete revascularization. And if you can do the first part of the procedure using virtually no contrast, it allows you to complete full revascularization.
I mean, I think that's a good argument with our objective to use this type of hygiene routinely, not necessarily as extreme as with the critical CKD, but it's a good practice to have if you want to look for complete revascularization, which is a much more of an imperative now, especially with STEMIs and ACS patients.
I think also it's a matter of experience. If you go this patient and you do with this technique, ultra-low contrast PCI, and you see that you use almost minimum number, and you know that you have the skills and you can go to the next lesion, and you are almost sure that you also use the minimum amount. So I think that this case could be done as a one session.
Something that I like very much of your presentation, Dariusz, is that you did not focus strictly in patients with renal kidney disease, but you elaborated that this can be useful in patients who are frail, in patients in whom, for example, have multi-vessel disease, and therefore by not performing injections, you may treat multiple lesions in one setting. Patients, I think that, so in a way, I can see that this is a great complement to the type of complex patients that we are doing nowadays, where we have to use multiple techniques of blood preparation, sometimes left ventricular assist device, etc.
So we
yes,
have,
I think we have a lot of questions.
Yeah, we have lots of questions. I will try to summarize some of them. So one colleague had a question about if you stage the procedure, is there an optimal time between the procedures that you would recommend?
Optimal time between the two procedures.
So if in the first procedure, if you have used more contrast than you would have liked to use, then I would wait a minimum of 1 week before doing the second procedure.
And not within 72 hours. There's a blanking period there where you actually increase the complications.
Sure.
Yes, I agree that usually we don't, many operators, they don't check, 72 hours, the contrast level, but it is the peak. So it's better just to be rather 1 week later.
There was also a comment of one of the colleagues about the definition of what is risk GFR. I mean, what is the limit that you decide this patient is going to have risk, and I would like to do this procedure saving as much contrast as possible. Is there a limit? What is your cutoff for that? About the GFR, would you consider the patient has risk?
So I'd go over 25% of what the pre-procedural eGFR was.
So,
sorry, creatinine.
The question is when we are going to introduce the ultra-low contrast PCI. So what is your cutoff for GFR?
Oh, sorry, no. So for ultra-low contrast PCI, eGFR less than 30. If they're diabetic, then I'd go for 45.
Yeah.
For
me, it could be 30, but as I presented, I think that above 30, we should slowly think about the, in general, low contrast, why to use what you know.
I mean, from a more general rule, if you have a patient who is an elderly patient who is diabetic, and that has GFR of 65, you already know that you have to balance the anatomy of the patient, what you're going to treat, and 65 millimeters cc's of contrast. I mean, that's something that is important. So it may be, more than enough for very simple stenosis. Perhaps it's with regular techniques, but probably if you are going to treat complex disease, then you need to apply an ultra-low contrast approach.
Yeah. But if your metric is 1 cc per GFR, right, then if you do that at 45, it's not ultra low contrast, but 45 for us is buckets of contrast. But you can still be disciplined with that, especially if their interaction with diabetes, heart failure, et cetera.
I think that's an important point that, for a lot of patients using these techniques, you will gradually reduce the amount of contrast you use in your day-to-day cases.
Yes. Nieves.
Yeah, another colleague had a
question.
question also about dialysis. Do you have potential scheduled dialysis in this kind of patients, or you're very confident that you will be able to do these cases with enough low contrast to avoid this?
So for all of our patients with EGFR less than 30, we ensure that we have the discussion with the renal physicians, that the backup is there if required.
But also we should mention that unfortunately many nephrologists during the discussion they will tell you, okay, so do your PCI, whatever you want. If you need, okay, so we'll put on dialysis. But our aim is, not to make patients to be ready for dialysis, but rather, to save the contrast, not to have. Of course, it should be discussed before, but better not to go to dialysis. That's the main goal.
In the room, any question before moving to the case?
That's one question. Yep.
Yes.
This is not a question, thought process.
What is it?
So first of all, we can use rosuvastatin as a statin of choice in these cases, although the data is limited. And some nephrologist colleagues still prefer to give N-acetylcysteine. They says that numerically it maintains the creatinine or cystatin clearance status quo. It may not give a beneficial effect. So this is from word of renowned nephrologist from India. But I don't believe it. The other thing is, if you have LV dysfunction, it may be prudent to put a PA catheter to make sure that you are not hesitant in giving enough fluid during the procedure. So that, I think, really helps in particular cases where LV dysfunction, renal GO40 both is there. And during the engagement, I have seen using cold saline, and the moment it engages, you get a ECG changes. And so you don't use the dye at all till you are cross the lesion. So this is the thought process.
Okay, thank you for the comment. Any?
Yeah, I think that some of the points that the colleague has mentioned, you will see them during the video, actually.
Yeah, but I think we have at least 2 randomized trials, and I could probably find more, with N-acetylcysteine, and I think that's been put to bed.
That's correct, yeah.
Good. I think we can move on, Javier, and move to the case.
Hello, welcome to Hospital Clínico San Carlos. I have the pleasure of being today with Pablo Salinas, my colleague, and also with our fellow Carolina Espejo.
Well, this was just a welcome from the cath lab that we recorded for you, because the case was intended. So the first step that we are using here that is important is that we are not using contrast for diagnostic angiograms. As you probably saw there, I'm going to repeat that for a second, we are using the images from the diagnostic angiogram displayed in front of us, and we are using this to guide engagement of the catheters and also, as you will see, to negotiate wires. Now, the colleague was saying before that you can make saline injections and then check if you are engaged. And it's true. I mean, that's exactly what we're doing here. So I had the impression that the right coronary artery was engaged. And clearly, when I injected saline, I could notice that there were changes of repolarization. So now we know that we are in the vessel. Well, it was quite easy, I must say, to negotiate the wire using as a reference the angiogram. From now onwards, what we use is diluted contrast. We take the contrast that we anticipate that we will be using as a limit for this patient. We dilute it at 50%. But now we face the first problem. IBUS will not negotiate because there is this very marked shepherd's crook. So we have the first problem with this. To solve it, I use a technique that is reverse trapping, that is extremely useful. I advance a balloon over one of the wires. anchor the second wire, and from that wire I advance the stent. So you can see that in that way I'm able to navigate the stent. If you're not familiar with the technique, I made a small cartoon. This is when you are deflating the balloon, you keep pushing the stent and then advance even further. So I will show it now in a short stent. Here you can see that there is one balloon that is holding the second wire, and by doing so, I am able to advance the balloon, the stent. Now the balloon is deflated, you keep pushing, bringing back the balloon, and then advances up to the position. Very useful tool when situations where you cannot use a guide extension catheter, for example, like in this case. Now we make sure that we are in the place where we want to deploy the stents. And before doing that, where we are just deploying the stent, as you can see, we rely a lot in these particular cases also with the stent and image enhancement. So it's something that helps us a lot. Of course, now that one of the wires is jailed by the stent, it's very easy to advance the IBUS catheter, and what we perform is co-registration, but instead of using the angiogram, what we do is we use the wire silhouette as a way of co-registering the images. So then we can know exactly the region that we are checking. The objective here is not only to check what is the status of the stent that we have implanted, also to see what do we face in the proximal part. We noticed that there was a lot of disease, so we perform now, before any further work, a longitudinal IFR analysis, and with some dismay, we found that actually there was lots of flow-limiting disease in this vessel, apart of that tight stenosis at the end. Again, we are co-registering this with the wire, so there is no need for contrast. And what we are doing here is testing different stenting strategies. If we treat these two stents in these two regions, yellow bits indicates the flow-limiting stenosis, we will end up with an IFR of 0.91. What about if we treat the other stenosis? If we treat the stenosis that is located in the mid-segment of the, let me see if this is working. Yeah, I think it should be coming now. If we treat this segment here, then we end up with an IFR of 0.92. So this is a more advantageous strategy, and we decided then to treat with the stents this part of the vessel. Sorry about that. So this is, we proceed then to stent. After predilation, we proceed to stent. You notice that we have removed one of the wires. The second stent is not navigating, so we go again to the technique of reverse strapping. We advance it to locate it. All the measurements of length were performed based on the co-registration of IBUS with the wire, and then we are deploying the second stent. Of course, as I mentioned, and probably what you are seeing at the left is also the stent enhancement system that allow us to see that we are overlapping properly the two stents that we are implanting here. And once that we completed the assessment, and what we try to do is to make a new measurement with IBUS, but there was difficulties in negotiating the IBUS, so we opted just to check with physiology what was the functional result. And so here you see the pressure guide wire being pulled back, and actually the IFR that we obtained with this stenting strategy was exactly the one that we had estimated beforehand, playing around and seeing which segments had to be treated. This is the final step where we were trying to advance the IBUS. It would not negotiate, and at this situation we prefer not to advance the IBUS. We performed the final injection. So as you could see, there were 3 injections of about 3 cc's of contrast each, because it was diluted, to complete the right coronary artery PCI. Before moving to the left coronary artery, perhaps, Jean, we can take a question, and then we will move directly to what happened in the left coronary artery.
I think we can make a stop. This is fascinating, because the first angiography reference and the last one, there is no contrast injection. practically.
Yeah, and
In
remember,
other words, you use
the quality you get with 50% contrast is, in many occasions, more than enough. In any case, if for whatever reason you have to get a very good image with full 100% contrast, of course you can make it. But the important aspect is not to perform all the injections in between.
There's a question from the colleagues here asking Javier, why didn't you choose a more supportive catheter, knowing the anatomy from the previous angiogram?
A more aggressive catheter, like an AL1, for example, or well, the point is that this. Remember that this proximal segment of the vessel was stented. By the way, I did not mention that it was at a different hospital, so we were not sure how it was stented, etc. The use of a more aggressive catheter in this situation could be, well, it has the risks, of course, of damaging the stent that is implanted in the proximal part. And probably in this way, what this technique that I shared with you, reverse trapping, provides an alternative to use, a less aggressive catheter, but still, if you need it, to be able to advance a gear into the coronary arteries in situations like this.
And I think also if you can use extensive hemodynamics, you really need to be able to match the pressures outside the coronary ostium, and that's very hard to do with the aggressive catheters.
That's a very good point.
Just one point, really. So I noticed, Javier, that, normally we rely on IVUS, but here the IVUS wouldn't cross the shepherd's crook. So at that point, you did give a small puff of contrast to guide positioning of the stent. And I think that's an important point that, at times you will give contrast to make sure that you've got the balance between safety of the procedure and efficacy as well.
I think at this point, how much contrast to be really used?
Well, I think that at this point, I showed you all the injections that were performed. I think that I showed you there were 3 injections. Basically, at the time of deploying, it was 50% contrast. So at this point, probably it was in the region of 12 cc's of contrast, or less.
At most.
Or less, yeah.
I think one more argument could be that if we use the Amplatz aggressive catheter with the right cannulation, it could be aortic dissection. Also, it would be needed to check with contrast. So that's why this safe catheter was providing additional safety. And with reverse trap, you are well supported with the delivery of systems.
Yeah, I think that was...
There's maybe one final question from the colleagues that I think is interesting is, if you're using dilated contrast, do you need more radiation? So you need to increase your frame rate?
That's a very good point. Thank you. That's an extremely good point. What we have learned is that when you use diluted contrast, because it is less viscous, it travels much faster in the coronary arteries. So what we typically do is using the high frame rate, 30 frames per second. That's a very good point.
But I think with contemporary systems now, that's the amount of gray is actually quite low. I mean, we do whole CTOs with 1 or 2 gray now with contemporary systems. So I don't think it's a real major consideration.
Radiation is not an issue because you are going to make so few injections. It's not.
And there's a colleague interested on how to perform the co-registration with the wire, but I'm sure you're going to show it in the next part of the case.
So shall we continue?
Explain it a little bit more.
Yeah, you can explain,
I'm sure that it will be... Well, we move to the left coronary artery, and here you can see that we're using an EBU catheter. Again, we are using the image that was obtained at the time of the diagnostic angiogram. Again, we are making sure that we have engaged properly the system. You can also... If you are not completely sure, you can try to advance the wire, and if the wire advances nicely, that you are in the place. So first step was understanding if this was a severe left main stenosis, and I think that there is no much doubt now that we have a severe stenosis into the left main with an IFR of 0.48. So with that in mind, we performed co-registration just to locate where the problem was, and I think that, again, we don't have much doubt as to what is the problem in the LAD, in the left coronary artery in this patient. So once that we obtain this information, well, we of course understand that we are stenting this, we will end up with a very good functional result. We have not explored the very distal segments of the LAD or circumflex. And next thing is using different wires to get a skeleton, so to speak, of of the vessel. Of course, you need it in this case because you are going to treat a bifurcation left main. So, and there's this obtuse marginal. So again, there was some issues in advancing IBUS. So we pre-dilated first. Now we are able to advance the IBUS. Remember that there is lots of calcium in this left main coronary artery. You can see it there. You can see it in the angiogram. And we confirm it, of course, with IBUS. Look at this napkin ring of calcium in the proximal LAD left main, which, of course, deserves some type of preparation, because otherwise you are going to have an underexpanded stent. So we move to IVL. It is easy. You, of course, no need to contrast up to this point. You know exactly where you are. Here you have the typical hits that you can see in the EKG when you're performing IVL. And based on the information that we have obtained, we have already implanted a stent followed by POT that you can see here. And we repeat the measurements with IBUS. And as you can see, the results were very satisfactory. It's true that we were, just very happy to see that the IBUS, the IVL balloon was fully expanded at 4 atmospheres. So we were confident that this will be treated properly. Areas obtained in the LAD and the left main were very good. And on top of that, what we did is we ensured that there was a good functional result. So you can see that these beautiful areas. This is the area in the LAD that is 8.6 millimeters in the functional result. I did not mention before that we had in this case an additional sepal wire in the valsalva sinus at the time of implanting the stent, and this is the final injection. And the final and only injection that was performed, I believe, in the left coronary artery, if I'm correct.
So with this, we thank you very much for being with us. We thank, of course, our patient for his generosity in allowing us to share the intervention with you. And we wish you a very nice course. Thank you.
And goodbye from Clínico San Carlos, Madrid.
And here you have a summary of the case. The total amount of contrast was 25 cc's. That means that if you divide the volume of contrast with GFR was below 1, I mean that's typically the ratio that you look was 0.83. The patient had an uneventful in-hospital evolution and discharged 2 days later. There was no modification in the serum creatinine levels. So it's I think that's John it's a case where we try our best to share with you all the different tips and tricks that you perform when you are doing this ultra-low contrast PCI.
It's fascinating. 25 ml to do the right and LAD. And LAD was complex, with 3 wires. The right was the shape of crows.
Complete
not easy.
vascularization, not 2 stages, 1 stage, yeah.
Yeah. This is really more than impressive. Thank you, Javier, to give an opportunity to share this type of technique. Any comment, Billal?
I think a really fantastic case. Just you mentioned about the extra wire, Javier. Just for the audience, can you explain that? Because I think many people, when you mentioned that we stent left main without contrast, this topic is often raised.
Yeah. So you are referring to the sepal wire that I mentioned.
Yes.
Yeah. So the sepal wire is a very useful maneuver when you are performing left main PCI. The reason is because, as you know, first, typically you have a lot of interaction between the guiding catheter and the stent that you are deploying. So we use it a lot to keep, you can see this is the sepal wire. So this wire is actually following the curve of the valsalva sinus and is telling us very clearly where the ostium of the left main was, and we were using that as a sort of imaging. But as I say, we also use it a lot to prevent interaction between the tip of the guiding catheter and the stent that you are deploying in the left main, particularly when you are deploying an stent that is undersized for the size of the left main and that is still pending of having POT.
Comment or question from the room, from the floor? from the chat?
Yeah, there are a couple of questions of the colleagues about use of extensions guiding catheters to decrease even more the amount of contrast. Is this something that can be done?
Absolutely, yeah. I mean, I think that you can use any intracoronary catheter or extension guiding catheter that you can use decreases the amount of contrast or make it more selective as well. So that's certainly a technique that you can use, absolutely. And they also have another very useful use if you are using OCT, and it allows you perhaps to perform saline injections selectively when you are performing selectively into the LAD with guide extension catheter. Then with saline you may be able to replace entirely the blood by saline, and then obtain very good images. I think that's something that Nieves may comment because she is an OCD expert. And particularly there are some extension guiding catheters that are transparent to light. Particularly the one that we use is the telescope extension guiding catheter, which perhaps because it is not braided, it is transparent, so you can use it to image even behind the extension guiding catheter with OCT.
And going back to the safety issue, with this type, some of colleagues were concerned about how you check properly the circ and the the intermediate branch in this case. How you make sure with only one injection that they are okay. What is your?
Well, the question, the answer is in the way that you think that is more reasonable or that dissipates any doubts that you may have. So, it may be a very good final contrast injection, or perhaps two, whatever, or it may be, using a pressure guide wire across the circumflex, understanding that there is no point. I think that in this case, we were confident that the images by IBUS were very good. But perhaps Jeff may comment, because Jeff has long-standing experience and he also may share a couple of tricks.
And I think it's time to review the microphone, Jeff. He will talk about the skills and tools that we can use in such patient to minimize contrast media injections.
Well, first of all, it's just great to be back live in Paris. So thank you all for going to the efforts of putting this on. And I'm going to give you a short course of this. First of all, the key to preparation, though, was hydration. We don't have a lot of tools to prevent it. And I think it's not very difficult these days. If you look at the Poseidon trial, with people over EFs of 25, you have an hour pre-hydration and then hemodynamically guided hydration during the case. And that's been a very powerful tool, number one. Number two has been what's been well discussed here. We won't go through the data, but it's the old 2.5 cc's risk ratio. For it, now we're dealing, as you can see here, 1 cc. So that's your headroom, that's your balance. There are some very, very specific tools. Number one, femoral versus radial. I mean, radial seems to reduce contrast use and CKD less. Minimize your views. As we said here, you can do this with 2 to 3 cc's for a left coronary, with, whether you're diluted or not, AP cranial and AP caudal. And an RAO, so far we're at 6 to 9 cc's for pretty complete angiogram in most cases. Dilute the contrast. And another thing, use a large field of view and don't pan. Yep. That's a very important aspect of this. Over a decade ago, Paul Tierstein and I put together a series of this, sort of discussing this as just sort of a little trick that we thought of, and it turned out to be very important. What's interesting here, if you look at the original paper, you can see a lot of the principles here that we're talking about now are actually, I'll give Paul most of the credit for this, of using limiting volume. When you exchange devices, back bleed always, don't have contrast in the catheter. Use an angiographic image that you have from a previous case, or from that case, a single image in front of you all the time. No puffing, and use IVUS liberally. This is just sort of one of the first examples from the original paper. And you want to look for engagement of the catheter. These are nuanced things. When you're engaging, you don't want to be puffing. You want to see it drop into the ostium of the coronary, and as you see here, you can leave saline confirmation. And here's just a good example of that, which you've seen already. All right. If you have dynamic roadmap, which I think is terrific, It's a very important tool. It makes things much easier. You don't need any panning. You maintain the same angle for the patient position. You can do it with 3 cc's. And also with the Philips system, you can actually return to that position automatically if you've had to move the II for other reasons. And if you don't have that, then you have the previous angiogram up in the optimal view, copied and in your in front of you on the screen. This is just a good example of what the dynamic roadmap can do, and it's a very powerful tool. Also, as someone mentioned, you can cover side holes with guide extensions to make the contrast go further. And also, you can use microcatheter injections, especially dual lumens, for the distal vessels if you have questions about that, also to minimize contrast to a half a cc or a cc. When you're wiring, I think I would avoid hydrophilics. I like wires that J. You're going blindly. It's safer. It doesn't get into small side branches. Personally, I believe like the Xi'an Blue or the BMW. And here we are. This is just how you wire using the dynamic roadmap. It makes it very easy. You can make right turns and left turns without injecting any contrast at all. Use fluoro and angio co-registration without contrast. And here with the IVUS, what I like to do is survey the vessel first, look at my proximal landing zone and my distal landing zone. I record it on the Cine with co-registration, and also obviously look at the plaque characteristics, which you saw here, to plan your treatment. So look at your proximal, your distal, calcification, and here's just an example of a Cine no contrast, and you have your distal landing zone identified. You have your length from your co-registration or from your pullback. All you need is one fiduciary point. You have the stent length, it's a given. You've seen this amply. I think the tri-registration has really enhanced it, allow us to do very elegant cases, combining physiology with intravascular ultrasound, knowing precisely lengths and placement of catheters. You can also, you've seen, this is redundant, you can use physiology with co-registration using the wire silhouettes, and the skeletonized coronary tree is very helpful, which gives you the landmarks to really, for your fiduciary points for placing all your devices. But also, I do try to minimize wire manipulation in these cases because there is compromised visualization. It's another reason I tend to avoid hydrophilic wires. But here's your example of metallic skeleton, but you saw an excellent example on Javier's case. And also, for a physiologic assessment, if it's difficult wiring, you can consider a dual lumen catheter over a previous place wire to minimize manipulation of the contrast. Just briefly, people are talking about safety. This is just a quick survey we did of cases that we did over a 12-month period over a year ago. These are the demographics. The point is the average creatinine was 3. With a GFR of 28, this is the entire cohort. The median contrast use was 10. There was a lot of zero contrast, but you can see the post, the 1-year outcomes, 9.2% cardiac, but there was renal replacement therapy over the year was 12%, but none of them were unplanned under 30 days. So I think this strategy, your concerns about renal replacement therapy, if you really have good hygiene, can be low. And this is just give you an example of the achievability. There are occasional outliers, you run into trouble, but as you can see here, in all these patients with the GFR into 45, 90% of them we were able to keep to that. So it is a feasible strategy, though once in a while, stuff happens. So the key points here to minimize views and contrast, don't puff, safe wiring, and maximize your co-registration with a prior still frame or dynamic roadmap. Use your IVUS or OCT with saline, MLD max. But I do believe to take one good angio for final safety, 2 to 3 cc's, just in case there were some distal wire perforations or edge dissections or branch compromise or slow flow. But that's, again, only another 2 or 3 cc's. Thank you very much.
Thank you, Jeffrey. Really thank you with amazing lecture. And I think we can move to the second lecture, Billal. And the question, I think, from in this room is how to incorporate ultra-low contrast PCI in our daily practice.
Super. Good afternoon. And it's fantastic being here, and it's great to see a pretty full lecture theatre. So these are my conflicts of interest. And the summary so far. So we know that, there's patients with kidney disease complex coronary artery disease, and that these patients generally do worse when it comes to outcomes. We've seen some tools here, such as dynamic coronary roadmap, IVUS co-registration, and there's multiple tools that we can use. And the question is really how we're going to incorporate this in our practice. There's a lot of data out there showing the worse your baseline renal function is to start off with, the greater your risk of developing contrast-induced AKI. And these patients don't do well because if you develop contrast-induced AKI, your mortality at 1 year is 25%. So this is something that we want to avoid. And also we've discussed patients whereby they've not necessarily got CKD, but may well benefit from a reduced contrast approach. So how do we set up an ultra-low contrast PCI program? So there's multiple tools, and I'm just going to quickly recap. You need a very good quality angiogram to start off with. You can use 50-50 contrast. There's tools we've got such as stent boost or device detection with sync vision. And then we've got the dynamic coronary roadmap. You've got wire maps, and IVUS is absolutely essential and key, and particularly IVUS co-registration is very helpful. Now, not to forget the basics now, in patients where we want to use ultra-low contrast PCI techniques, generally we find these is a complex group of patients. They have got complex anatomy, they've got multiple comorbidities, and are more at risk of hemodynamic compromise. So we mustn't forget the basics including prehydration, stopping drugs that might affect the kidneys, do anything to reduce bleeding, avoid double hits, so you don't want to do an angiogram and a PCI within sort of 2 to 3, back-to-back on these patients, avoiding shock, and make sure you've got a plan for renal support if they've got poor baseline EGFR to start off with. Now, what if you don't have IVUS co-registration? So, you don't have to have the software. There's other ways that you can use IVUS and co-registration. You can do a manual co-registration, taking CINIs. So that's other ways how we can use the technology. So how do you set up an ultra-low contrast PCI program? Case selection is absolutely key. Start with the simple cases. Now, you may well see some of our presentations showing quite complex cases, but really it's a journey that you want to take, and you want to start off using the techniques shown and the tools in simple cases. Get through a habit of reducing contrast in daily practice, contrast hygiene, and generally we'll find using the tools, you can significantly reduce the amount of contrast we use in day-to-day PCI. Use the tools that we've got, IVUS, dynamic coronary roadmap, and co-registration. And you want to shift really from, I'll call it a normal contrast practice, to low contrast, and then ultra-low contrast PCI. And once you develop the skills, it's quite easy to implement this into your practice. And then when the need actually arises where you need to perform complex PCI using ultra-low contrast, generally you find the patients that need this technique have got complex disease. You've got the whole skill set there to be able to do this confidently because you've built it up in the right sort of way. And training is absolutely important as well, training of yourself, training of the cath lab team using the technology. So IVUS co-registration on the wire. So this is just really a demonstration of, when we do the IVUS co-registration, we're doing a manual pullback here, and then we co-register on the wire. So the software automatically co-registers, but there's a bit of a lag on the wire, and now manually we're co-registering on the wire. The wire is a surrogate for the vessel. And you can do this really in any case. It doesn't have to be a CKD patient. You can get used to this technique because it's a surrogate for the wire. And using this, you can then do the PCI procedure pretty safely without putting the patient at any increased risk. So now, once you've done the co-registration on the wire, when we you can actually use this to guide stenting. And now we see, that it will show you proximal distal landing zone. We've performed IVL in this patient. You see fractures in the calcium there. So if you were doing this case, there's nothing to stop you co-reging on the wire, doing all of this, but for your confidence and peace of mind, you can give a contrast test now and go ahead and stent. What this will do is it will get you used to the technique, used to the technology, and then you'll be able to progress to where actually the need is required, where you don't need to give contrast. So the idea is to reduce the dependence on contrast, and these skills can be safely developed in standard PCI. So, what I'm not asking you to do here is drive in the dark and turn your headlights off. That's not at all, because bear in mind, the IVUS is guiding you, and at any time you can give a contrast puff if necessary, and that's a very important point. So how are you going to set this up in your practice? So first of all, you need a good angiogram with no panning. Co-registration on the wire, Give contrast at any time during the learning curve, because in the learning curve, you can do this in your standard day-to-day practice. Plan the PCI based on the IVUS, and then reduce the dependence on contrast case by case. And then your result of your PCI, you'll use the ultimate criteria to make sure that you have got optimal outcome. Now, there's so much evidence of use of IVUS. There's so much evidence of use of IVUS in CKD. So really, it becomes very difficult to not use IVUS in this group of patients anyway. All you're doing is you're getting a very good longer-term outcome, but also you're developing the skill set to manage this group of patients when the need really arises. So, this is our step-by-step algorithm of how to use the IVUS core registration. And this is a series of quite complex cases, left main bifurcation in DK crush. So this is the algorithm that we use using the IVUS core registration. But just to bear in mind, this is not the sort of patient that you want to be starting off on. However, the algorithm can be used in straightforward PCI for the simple case to get used to the technology. It's not a question about all or nothing. It's not really about how low can you go. Very important, we want to balance safety and outcome here. And what we generally use is as low as reasonably possible in patients with CKD or in patients that are frail, that have got other indications to reduce the volume of contrast, such as patients with heart failure, high LVEDP. So setting up the program, our Blackpool experience. So having the software core registration at Sync Vision was a big factor. So when any new piece of technology comes, generally the sad faces in the cath lab saying, oh, here we go again. Now, how are we going to manage this? But actually, with the technology, and once the team saw the benefits of IVUS core registration in certain groups of patients, very suddenly we found that there was a huge enthusiasm, and the team we were able to actually develop the program with the whole team together. So in terms of the cath lab team, you need the radiographer, important for the views, the angles, and to make sure that the X-ray table doesn't move. You've got your technician who's going to help you with the IVUS core registration and the measurements. This is your fellow or senior consultant assisting you, particularly for the more complex cases that you're doing. And then you've got the nurses who are going to ensure that the rehydration protocol is followed and any other assistance and support is needed. So in Blackpool, I said, we got the software, and then we had, myself had a big interest in this field, and then another couple of colleagues joined us, so we had a team doing these procedures, and that helps. Amongst the cath lab team, we identified certain members that would be super users that would assist us in these cases. Generally, then, the enthusiasm within the lab increased, the enthusiasm amongst our colleagues increased, and we were doing more and more of these procedures. Send our staff onto the simulator course with Philips, and like anything, you need to practice, practice, practice. So Bruce Lee would say you do the same kick 10,000 times rather than doing multiple kicks several times. And it's the same in the cath lab. The more you practice, the more things become easy. There's the concept of the cardio-renal team to involve your nephrologists, because it's important. This group of patients generally get a bad deal, and to have that link and liaison with the nephrology team is very, very important. So in summary, we've talked about the why, we've talked about tools, the PCI complex journey from simple to complex using very low contrast, the step-by-step algorithms, cath lab team, and the cardio-renal team. And I'll just leave you with this quote, that you do not rise to the level of your goals, but fall to the level of your systems. And in the cath lab, systems is absolutely key and crucial, particularly developing an ultra-low contrast PCI program. Thank you.
Thank you, Billal. And Nieves, some final question?
Yeah, I think
Along
one of
these,
the,
lectures?
just one final question that was repeated by some colleagues is the concern, can you do these cases without the software for co-registration? Can you co-register your IVUS without, I think you had a slide about that, but maybe just a final remark on that.
Yes, so you don't have to have the IVUS core registration software, and you can do it without. You can either do a grab of the screen or a cine, and I think, Jeff, you showed that as well in your presentation.
I think if you have multiple, that's where I would do more wires, septals, diagonals, and really, it's basically your co-registration points. It really makes it easy.
I think that's most of the questions have been answered.
That's okay?
Yeah.
Fantastic. Javier, the final words.
Well, thank you. I mean, I think that what we want to share with the colleagues is that this is the first step, perhaps, to move away from the paradigm of PCI based on contrast opacification of vessels. I mean, it's something that has been there from ages. We perhaps never challenged the idea that this was feasible. But as you could see, one of the benefits is not only that it allows you to perhaps perform longer procedures which otherwise would be limited by the amount of contrast you give, but also implementing tools that we know that they contribute to a better quality of the procedure, like imaging, physiology. So all this comes in the same package. At the end of the day, this is something that we develop for our patients. Because one of the major challenges of these very complex patients is that they need, like any other patients, a very high quality revascularization. And we know that probably that was not the case. So typically in the past, someone, for example, with chronic kidney disease, the strategy would be go very fast, place a stent, go out. And if you're going to do it, you have to do it right. Because these patients are challenging, they really present many challenges to perform proper revascularization. So hopefully, what we have shared today with you, that you can of course start to implement from tomorrow, because it's something that is at the access of everyone, will help you in expanding your ability to treat these complex patients in a safer way and more effectively.
Okay, thank you. And it's a really fascinating concept, ultra contrast PCI, and I would like to thank all of you, Billal, Jeffrey, Nieves, Dariusz, and you, Javier, and thanks to Philips to give us the possibility to organize this kind of symposium. Have a nice day.